So I want to welcome you all. It's great to be back in our not the same day, but our 12 o'clock contemporary Jewish thought time slot. Today's program is a special program in honor of Mental Health Awareness Month. It is my pleasure to introduce our guest this afternoon, Dr. Cary Gunther. Dr. Gunther is a board certified in neurology, psychiatry, and brain injury medicine. She earned degrees from Harvard, Rockefeller, and Cornell universities. She serves patients in New York and Florida living with cognitive, mood, and behavioral symptoms of neurological disease. Dr. Gunther's areas of expertise include traumatic brain injury, Alzheimer's disease, Parkinson's disease, depression, and anxiety. Dr. Gunther is an award-winning teacher of residents, physicians, and medical students at Weill Cornell Medical College. She lectures nationally and serves as an expert witness in cases involving neurologic and psychiatric disease. Dr. Gunther, thank you for being our guest here in Contemporary Jewish Thought at Park Avenue Synagogue. I also want to acknowledge on the Zoom our social worker, Suzanne Redlick, who will also be part, I know, at the end of this presentation. But Suzanne, thank you for all that you do on behalf of our community. And to remind everyone that you can please place questions, use the chat. You can put questions into the chat, and we'll get to those questions at the end. I don't think that we'll be dealing with questions as they come up, but please put them in the chat and we will do our best to address them. And with that, Dr. Gunther, I want to turn it over to you, and thank you again in advance for being our guest and our teacher this afternoon.
Thank you, Rabbi Zuckerman, for both the invitation and the introduction, and thanks to Suzanne for being my point person on this. And I know that there have already been some questions that have been sent our way, which I'll be happy to get to at the end. I'm just concerned that I would miss hands up if they were during the chat. But I want to say in advance that one question that I heard about that I love is how do I support a friend or a loved one who's grappling with dementia? So thank you to whoever raised that question. And if I don't address it adequately during the talk, please remind me of it, because I really want to make sure that I do. So I'm going to share my screen with you all now. Okay, we're set. Everyone can see my slides? Great. Okay, so I'm going to talk to you today about dementia, which is a subject about which I have spent a great deal of time studying and practicing, and yet I'm still learning, and I hope I will always continue to learn. I've broken my talk down into a few large categories, and I'll give some specifics. I'm going to start by just going over some definitions. It's always important for us to be using our words the same way, so that what I'm saying is what you're hearing. And then I'll speak briefly about some of the biological causes of dementia. I'll talk about what you could expect if you were to go on your own to see a memory disorder specialist or even a primary care physician who looks into this, or what you could expect if you were accompanying a friend or a loved one. Some things that we know about in terms of trying to prevent dementia. And then finally, I'll wrap up talking about some of the treatment options that are in the landscape. So starting off with definitions. So I want to distinguish two terms that you might hear about a lot. One of them is dementia, and the other one is mild cognitive impairment. So dementia, and I've bolded my words that I think are key to these definitions. So dementia really just means progressive cognitive impairment that affects memory and other cognitive domains, but usually memory is at least a part of it. And it's severe enough to cause day-to-day dysfunction. So it has to be getting in the way. I know a lot of people think about what's healthy versus what's a warning sign. When how we function or how we get through our week or how we accomplish things, when that's changing, that's when we want to be starting to think about whether something is, more than just healthy aging. Mild cognitive impairment, it means a change in cognition. So there has to be some change. It's greater than what's expected for age, but it's not so severe as to compromise our independence. People who are given a diagnosis or a description of mild cognitive impairment, they definitely are at increased risk for eventually receiving a dementia diagnosis, and they might choose to take additional steps preventive steps, but they haven't been given that kind of severity descriptor yet. So what does healthy aging look like? By the way, this slide is a shameless plug for Tai Chi. I strongly encourage people to do Tai Chi if they are at all intrigued. I think it can easily be compatible with Judaism. It doesn't have to be a religious practice. Tai Chi is great for cognitive engagement. It's also lovely for getting outdoors, and it's fabulous for balance. It's been actually studied in a couple of disorders, including Parkinson's disease, and it prevents falls. So here you see two lovely, healthy Tai Chi practitioners. So healthy aging is still aging, right? We don't get to stay 25 forever. God willing, if we live long enough, two things will happen to all of us. One is that we'll all experience at least a mild vocabulary restriction. Maybe the words are still in there, but reaching for them is a little bit more effortful. It'll be particularly true of words or names that we don't use very often. But those words, if we were to hear them, they would feel familiar. So just a mild vocabulary restriction, that in and of itself can be something that we don't have to worry about. Another thing that will happen to all of us is that we will all slow down. So if I could get in a time capsule and give you the same sheet of math problems at ages 20, 50, and 80, you would do them fastest at 20, slightly less quickly at 50, and slowest at 80. Even if you got them all right, you would still slow down compared to yourself. So when we start to see things outside of those two kinds of changes, that's when we think maybe we are getting a little bit concerned. So there are a few different parts of cognition that can change, and I'll describe each of these to you a little bit. So first of all, memory. Memory is what it sounds like, right? It's holding on to things and being able to call them up later. The way that we might see changes in memory could be things like misplacing items, repeating oneself, especially within a conversation, and especially for someone who's not just known for telling the same great story, or missing appointments, or missing bills, double paying bills. And also sometimes trouble with keeping track of medications can be an issue there. And I'm a big fan of multi-day pill dispensers, actually for anyone who's on a bunch of medicines, even if there isn't a known memory complaint. Human beings and doctors in particular are notoriously terrible at taking medicines. So one of those, $2.50 weekly pill dispensers is actually a good friend. In addition to memory, language can change. So I mentioned the vocabulary restriction already, but other things like making word swaps, or losing common words, having to reach for things, having to reach for approximate words. I say sofa because I can't quite come up with desk. I pick a word from the same area, but it's not quite the right word. Executive function is another part of cognition that can change in people who are developing dementia. Executive function can be a little bit hard to define. The way that I usually describe it is that it's your brain's CEO job. Any part of thought or action that's involved in planning, synthesizing information, executing, and also course correcting, those are all parts of executive function. So we might see problems with executive function in someone who struggles to organize a trip and starts to decide not to travel anymore, or someone who likes to cook but who's making simpler meals because keeping a few different things going is more challenging. Around tax time, people can get really overwhelmed. Even if they're not doing their own taxes, they're still assembling documents for an accountant. And also inflexibility. People who struggle with executive function will want things to be done in a very fixed way, and any kind of deviation from that can throw them into a tizzy. Praxis is another area that can change. So praxis means the ability to carry out coordinated movements. So think of it as like your brain's software when your muscles are the hardware. So if you have the strength to lift a fork to your mouth, but you don't have the coordination to do so, that would be a loss of praxis. And in a variety of different types of disorders that cause dementia, you can see loss of praxis over time. Visuospatial functioning is another one, and that particularly affects driving. I actually love for my patients to go have an occupational therapy driving evaluation. So an occupational therapist gets in the car with you and goes for a drive. And by the way, if you want resources for this, I can certainly get them to Suzanne to pass out afterwards. In New York City, obviously a lot of us don't bother to drive. I personally don't. Having been raised here, I have to say I'm a proud New Yorker non-driver. But the OT's job is not to shut you down from driving, it's to give appropriate recommendations. And another thing that they will do in the assessment is the occupational therapist will put in writing, that this person is a safe older driver. And so if you were to, let's say, get into a fender bender that's not your fault and your car insurance is giving you a hard time because the date on your birth certificate is in the 30s, you can actually compel them to pay by showing that an occupational therapist certified you as a safe older driver. And then lastly, comportment. And by that, I mean, behavior in social situations. Things like becoming withdrawn in social situations or becoming disinhibited, like saying things that are inappropriate, that are out of character. So not just being jocular, but being jocular in places where it doesn't belong, or someone who never used to use profanity, but who all of a sudden does. That's a change that would get my attention. So I've told you some of the things that characterize dementia as being a change from normal cognitive function. I want to get now a little bit into causes, right? So dementia is really the constellation of symptoms. It doesn't tell us, using the word dementia doesn't tell us what is going on in the brain. So Alzheimer's disease is the most common cause of dementia. Alzheimer's disease is really common. It starts at 1% of the population around age 60, and it doubles every 5 years. So by the time that we reach 85, close to a third of the population has it. That doesn't say anything about what the severity is. It just says that the underlying cause of cognitive change in those people, like if we were to be able to look at a slice of their brain under a microscope, what we would find is Alzheimer's disease. So Alzheimer's disease was originally a pathologic diagnosis. So Dr. Alzheimer was a pathologist. He did autopsies, and he looked at brains, and he saw two proteins, one called amyloid and one called tau, that were deposited in the brain in ways that were not typical of normal healthy brains, in kind of post-mortem examinations. Nowadays, thank God, we have the ability to take a little bit of a look without doing something quite so invasive or without waiting until the end of life. So amyloid is something that is on the outside of brain cells or neurons, and tau is a protein that clusters inappropriately inside neurons and affects the health of those neurons and of other cells in the brain. So the top picture here is actually looking at a PET scan that is basically like looking at brain activity and amyloid accumulation in a PET scan of somebody who's normal. This is, I should say, this is a cross section. So imagine that this is someone who's lying on his back or her back with feet sticking out of the table. Okay. So you can see that changes going from normal to somebody with mild cognitive impairment to actual Alzheimer's dementia. That's what it would look like. And the bottom slide is, the bottom image is just looking at, so the brown is amyloid that's on the outside of cells, and the tau is the tangles that are inside of the cells that are affected that you can see here. Okay. So, but Alzheimer's disease is the most common cause of dementia, but it is not the only cause of dementia. And there are a few others that I'll mention here. One is strokes and cerebrovascular disease. So as we age, the blood vessels in our heads age along with us. In the same way that everybody gets a little bit of heart disease as we get older, we all also get a little bit of brain change from blood vessels. So everybody's going to have some. It doesn't always add up to be enough of a problem to really adversely affect memory and cognition, but sometimes it does. And people who have that kind of history, people who have cerebrovascular change as their cause of dementia, they'll tend to have had specific time points at which they can identify, or the family can identify, when things got harder. As that's a little bit different from an Alzheimer's disease, where it will tend to be more of a gradual slope of decline. Lewy body disease is also something that has been in the press at times because there have been a few famous people who've had it. So Robin Williams was one. So Lewy body disease is like a combination of movement changes and also memory and thinking changes. And it can come with a lot of anxiety surrounding it. So that's another that person's brain would look different from the Alzheimer patient's brain, but they might still both wind up being described as having dementia, meaning having enough cognitive change to get in their way. Parkinson's disease, I think people have a sense of what that is. But we know it mostly as a movement disorder, right? We see people moving slowly, having difficulty with shuffling, walking, having difficulty with tremors. That is certainly a big part of Parkinson's disease, but Parkinson's disease also affects memory and other aspects of cognition. And it is a common disorder that can eventually progress to cause dementia. Then frontotemporal degeneration is less common, and it involves a bunch of different disorders that I've listed here, and I won't really go much into unless somebody has a question at the end. But basically, the front parts of the brain are responsible for things like mental flexibility and certain aspects of speech and control of behavior. And so when those areas are affected by degeneration, you'll get a specific kind of look to the dementia picture. Then there's another cause of dementia that's called normal pressure hydrocephalus. That's when the fluid spaces in the brain get bigger. I bring this up and I'll talk about it a little bit later, but not because it's so common, but because it's actually quite treatable. And so we never want to make a mistake and miss something that is really easy to treat. And then lastly, I think we've heard over the years in the press the story of CTE, or chronic traumatic encephalopathy. This is what can happen to football players or people who have repetitive head injuries. So the picture on the right is Junior Seau. So he was a football player for the Chargers and the Patriots, who unfortunately and tragically ended his life when he was in his early 40s. He had CTE and he knew something was drastically wrong. And he actually ended his life in such a way as to preserve his brain because he wanted somebody to take a look so that other people wouldn't have to go through what he did. So that was, CTE is very famous, but it's actually not common outside of that outside of the world of people who really are having multiple, like tens of thousands of head decelerations over time, the way that a football player might. Okay, so now that I've talked to you about, the different causes of dementia, what could you expect if you were to go on your own, or if you were to accompany someone you care about to see a physician to have an evaluation? Well, first up, hopefully your doctor will listen to you. I realize we are sometimes infamous for not doing enough of that, but we try. Your physician will want to hear about what's going on right now, right? What has changed for you, in the ways that we were talking about in your daily functioning. What are the things that should be easy for you that have become harder? And also we'll want to take a thorough past medical and surgical history. We want to make sure that any other contributing factor is thoroughly investigated. And then your doctor will do a neurologic evaluation. So what I've put over here in the top half of the slide is what's called the homunculus. So your neurologist is actually a detective. This is one of the more fun parts of my job, is getting to play detective. So every part of your brain basically maps to a different part of your body or a different part of your mental functioning. And so your neurologist will do a thorough physical neurologic examination, things like looking at reflexes, looking at coordination, eye movements, gait. You can actually learn a ton from just having somebody walk around your office. And that will give a sense of what parts of the brain might be misbehaving or might be contributing to the clinical picture. And then also your physician will do a little bit of memory testing. It depends on who you see as to kind of what gets weighted in what way. The image in the bottom is a page from what's called the Addenbrooke Cognitive Exam. I picked it actually because it's not that commonly used. I didn't want to put up an image of the most commonly used memory tests because I don't want to be guilty of a spoiler. But things like having you name things, having you switch back and forth between sets of items, having you do certain timed tasks. Those might be things that you're asked to do. And again, your doctor is trying to build a map of what's going on in your brain. In addition to the physical exam, your physician should be checking some laboratory tests, and I've listed some of the ones that are here. Most of the laboratory tests that we use are ones that you would have checked in an annual primary care visit. Every once in a while, I add on something to what I get when I get a patient referred by an internist, but usually what I need is there. So what are we looking for? With things like a blood count or a metabolic profile, we're looking for whether there might be anemia or whether there might be signs of other systemic diseases that can contribute to memory change. Also, if we're going to be prescribing medicines, we want to know what are the other medicines that you're taking or are likely to need. We want to monitor for interactions. Don't want to give you a medicine that's going to exacerbate a problem that you already have. I mentioned urinalysis here. So urinary infections are actually really common causes of delirium or very acute cognitive change in people who might on an ordinary day have very, very mild symptoms of memory difficulty. Like in the setting of a urine infection, that person could look really quite confused. And then, obviously treatable things like vitamin deficiency, we want to make sure that we evaluate and reverse if needed. And then at the bottom, I mentioned disease-specific markers. So depending on what's in your medical history, your doctor might add on specific tests, whether that's levels of medications that you might be taking or something called a hemoglobin A1C, which is like a marker of diabetes and risk for diabetes. All of these things interact with your brain health as well, right? So they're definitely things that we want to look at and test for. By the way, I did not list in that in the list of laboratory tests there. I did not list genetic tests. We don't routinely do genetic tests in people who are coming in for a first visit for a dementia workup. And I can talk to you a little bit more about this at the end. But the short story behind why we don't routinely do it is it doesn't. It gives us a shading of risk, like an idea of you're at more risk or you're at less risk, but it doesn't necessarily give us a concrete answer. And it can open up a can of worms in terms of, what do you know? What have you told your children? What are you or are you not going to disclose to others? So if there's genetic testing that's done, it's typically for me, at least in my practice, it's something that I would do later on and only after getting to know the patient better and kind of being sure that I understand how they think about risk and what that testing is going to mean to them. But I do love pictures of people's brains. When I was in neurology residency, I had at one point an attending who drove me nuts. And he used to say over and over again, if there's no scan, there's no plan. What I've shown you here is an MRI or magnetic resonance imaging of a healthy brain and an Alzheimer's brain. This is what's called a coronal section. So meaning it's like through the face. Okay, so this person is standing looking out at you. So there are a couple things that you can see. So one is the dark spaces here that are the fluid spaces, right? So we're supposed to have fluid spaces, but the Alzheimer's brain is, as the brain shrinks, the fluid spaces are going to get bigger, right? Your skull is a fixed size by the time you are probably a young teen. So if your skull stays fixed and your brain ages by shrinking, then something's going to take up that space. And one hopes that it is fluid because you don't want it to be something else like blood. So fluid spaces will definitely get bigger. But also sometimes there's a pattern of how the brain ages. So I joke with my patients that our brains are the only part of us that effortlessly gets thinner with age. The rest of it we have to be mindful of. If you can see my cursor, so right here, this structure here, that's kind of, can you guys see that? Yeah, okay. So that's the hippocampus. It's felt to be sort of seahorse shaped, which is kind of how it got its name. But that is the part of the brain that is most directly responsible for consolidating memory. And it's also a part of the brain that tends to age very quickly and get very skinny in people who are developing Alzheimer's disease. So sometimes the MRI will show that pattern of aging. An MRI or a CAT scan, a CT scan, if the person can't have an MRI for some reason, whether that's claustrophobia or some kind of metal implant, CAT scan is, it's a less kind of fine picture, but it still help. The other reason for getting an image of somebody's brain is to make sure that you're not missing something crucial. I certainly wouldn't want to give somebody a diagnosis of Alzheimer's who actually had a brain tumor and just it was pressing in the right place and causing the right symptoms. That would be obviously a drastically bad mistake. So the neuroimaging can help rule out things that would really send us in a very, very different diagnostic and treatment direction. Okay, and then there are other tests that you might or might not see done depending on what the doctor is thinking. I would say pretty much everybody's going to get a physical exam, some basic blood tests, and some kind of image of the head, whether that's an MRI or a CT. Other tests like PET scans, EEGs, or even cerebrospinal fluid exam are less common, and they really depend on the specific discussion that you're having with your doctor in terms of what the doctor thinks is likely, what they need to rule out, what they need to dig further into. Okay, so I always want to make sure that we are thinking about prevention, and prevention is there are preventive health experts who can actually talk about this in an even more fine-tuned way, but grossly, I'm thinking about what's called primary prevention, which means taking steps in the hopes of never having to confront a certain problem at all, and secondary prevention, which means taking steps so as to make sure that if there's a problem, that it doesn't progress any more than is unavoidable. Primary prevention is all about lowering risk of dementia. Any dietary changes that we make are really going to be most effective if we make them kind of in the middle of our life or earlier. But that doesn't mean that we should give up. We should always be thinking about that there is room for improvement. In general, with regard to diet, what's good for the heart is good for the brain. So if we're thinking about diets that are not, hugely rich in saturated fats, diets that are not, kind of overkill on sugar, the brains of people who have Alzheimer's disease specifically don't process sugar as well. So it is good to be mindful of kind of how much sweets or how much pure sugar there is in a day. I don't like to advocate for exclusion diets because I feel like they overpromise and underdeliver, and I like to also meet people where they live. So dietary change is hard, but I would say as two rules of thumb, number one, when you look at your plate, you want to see more plants and fewer animals on it. And number two, when you think about how you get your food, you want to have more foods that come from ingredients and fewer foods that come from a box or a package. I think if you can kind of go with those two ideas in mind, I think you're on the right track. In addition to diet, exercise. If anybody here, knows anyone who has seen me in the office, they will know that I bore people to tears with how much I talk about exercise. The best kind of exercise is the one that you will actually do. There are proven benefits to each type of exercise. And every once in a while, you'll see something like in the Wall Street Journal or whatever paper you read about, this new strength class that everybody's talking about that's really the next best thing, and it's been shown to help prevent Alzheimer's disease or something else like it. And that is probably true. But if that exercise form is actually completely not doable for you for health reasons, or you're never going to get there, or it's just not realistic, that's okay. The other ones are great too. If you can have a partner who helps you get exercise done, that's wonderful. I love when people tell me that they take long walks for exercise. It can be a time of getting away from screens. It can be a time of getting away from craziness. It's great for your mood, getting outdoors, getting some natural light. Hey, maybe walking with a friend, so socializing a little bit along the way. But really anything that you will do, all of strength training, exercises that focus on balance and agility, and exercises that get your heart rate up. If your doctor feels that that's acceptable for you, they're all great. I also like to think about, in terms of primary prevention, adding by subtracting. So by which I mean, Um, thinking about things that we are doing that we could do less of to help our health, rather than just piling on more and more medications, right? So, um, honestly, from a cognitive standpoint, nobody should drink. Again, I like to meet people where they live. So if having an alcoholic beverage here or there is part of how somebody socializes, I'll try to talk with them about, kind of ways to reduce or sort of restrict to only certain social circumstances or whatnot. But basically less is more when it comes to any kind of, what we typically think of as vice. And that, and also in terms of adding by subtracting, if you can, let's say, get on a good schedule of early morning walks so you get some sunlight so you're sleeping a little bit better, then maybe that sleeping medication that's not so great for your brain in the long term, maybe it becomes a little bit less necessary. Or maybe you can't get rid of it entirely, but you can use a lower dose so you're only using it on the occasional night as opposed to every night. By the way, the people in this video are doing Pilates, which is great for posture and spine strength and not losing inches. Okay, so in addition to our diet and exercise measures, we're going to be thinking about optimizing our general health. So anybody who comes to see me who doesn't have a solid relationship with a primary care physician is going to get one. You need a team captain who's thinking about your whole body and not just thinking about the things that I bring up. There's an expression in medicine, and I think in other fields too, if your only tool is a hammer, then all you see are nails. And I'm definitely as guilty of that as the next person is. I know my business and I think about it first and foremost. So I really appreciate all the great primary care docs out there who are synthesizing my suggestions with, uh, kind of taking care of the person's overall health, and especially cardiovascular risks. I mentioned that cerebrovascular change in and of itself can cause dementia, but even if it doesn't cause it, it makes matters worse. If someone has the beginnings, for instance, of Alzheimer's disease, but also has a lot of cardiovascular risks, and those risks aren't adequately treated, then that person's cognition is going to decline faster, and that's a concern and something we want to avoid. Again, in the spirit of adding by subtracting, so if we can treat sleep difficulties, I know sleep is such a bear, right, for a lot of people, and particularly for people around retirement age. So first of all, there are brain changes that actually cause you to be able to get less sleep as you age, and it seems a little bit like ironic and unfair, right? That just when you get to the point in your life that you maybe should be able to relax a little bit, and you're not having to get up at 6 to get on your commute to work, all of a sudden your body and your brain have decided that actually 5 is a great time to get up. But if we can think about ways to address sleep that aren't just piling on more medication, then that's to the good. So one of those is what's called cognitive behavioral therapy for insomnia, or CBTI. There are behavioral therapists who do it, and also there are computer programs that do it. Like you can do a web-based, you put in your sleep parameters and you get printed out like a specific schedule for when you're going to try to go to bed, when you're going to get out of bed if you're not sleeping well enough, like what are the kind of behavioral tricks that you can use to try to improve your sleep. And then also, so CPAP, or continuous positive airway pressure, is a treatment for sleep apnea. So sleep apnea is an incredibly common problem that can affect your long-term attention span and also your ability to consolidate memory. So there are processes in your brain that occur at night that basically take things that you've learned during the day and turn them into things that you can hold on to for longer. Those processes aren't so effective if there's not a good long stretch of sleep. And so if sleep apnea is making you wake up for 3 seconds out of every 20 minutes, that actually is a lot of awakening, and it can really disrupt your memory. So we definitely want to treat that, treat sleep apnea if it's there, to improve long-term cognitive health. And then lastly, in the prevention category, is treating hearing loss. So people with severe hearing loss tend to be very happy to get it treated because they are aware of how much they're missing. They miss out on conversations, they miss out on enjoyable activities. They want to fix the problem, and so they do fix the problem. People with mild hearing loss tend not to fix the problem because they aren't aware of what they're missing. And what they're missing is environmental noise. So things like radiators humming, clothing rustling, the sound of the wind, the subway rumbling, the sound that your hair makes when it rubs on your shoulders, the sound that your clothing makes as you move through the day. Those tiny little noises are actually incredibly valuable to your brain. Your brain needs them as anchors to help it pay attention. And so you will actually, ironically, you will remember what you read better if you are wearing hearing aids when you're reading, because of the little environmental noises that you will correctly pick up on. Falls prevention is also part of dementia prevention. No one's life was ever improved by a fall. So I talk to my patients a lot about, first of all, removing obstacles. So whether that's clutter, whether that's one partner being vigilant on behalf of the other, like if people, people who share a home, things like bath mats should actually be over the shower rail at night. They should not be sitting down on the ground. Those adorable throw rugs that are so cute in your home, they might be less of a great idea as you age. And you want to, think about what you're wearing on your feet when you're around your home as well. For people who live in houses, sometimes it's things like choosing to use the first floor bedroom so that there just aren't quite so many up and down the stairs. And that's a hard sell, I know, but it is sometimes worth doing. Also adequate lighting matters a lot in terms of falls prevention. So things like having a low night light on the path between the bedroom and the bathroom, or having a light night light in the bathroom so that the person isn't scrounging around for the light switch. Physical therapy where appropriate, just to make sure that the person is as strong and well balanced as possible, and Tai Chi again, which I'm always throwing in. And then limiting sedating medicines to prevent falls. I think many of us have probably had the experience of, if we've not fallen ourselves, but then being with somebody we love who's in the emergency room after a fall. And in addition to just the physical toll that it takes, the ER itself is a really exhausting, like overstimulating kind of casino, no windows, no clocks kind of environment, right? It can literally drive you mad. And also once you're there, you have many cooks who are going to spoil the soup, right? Everybody's got an opinion on what's best for you. So avoiding falls means avoiding the delirium that happens in the hospital, and the infection from being in the hospital, and the pain medicines that make everything worse. So falls prevention is huge, and is something that we can take seriously, honestly, without physicians involved, right? We can be just thinking about that in our own homes and lives. And then engaging. So, okay, I had to throw out a couple of family pictures because it's just fun for me to do. Basically, any kind of cognitive engagement is good. People ask about things like, should I be doing Wordle? Should I be doing crossword puzzles? Puzzles are great. And if you like puzzles, I wholeheartedly encourage you to do them. But there's nothing special about puzzles. There's nothing magical about puzzles. If that's not your jam, do something else. There are many types of mental activity that have been evaluated for their potential benefit. And basically, they are all mental stimulation, with the possible exception of extreme stress. All mental stimulation is beneficial. And the most beneficial forms of mental stimulation are those that involve people on the other end. The challenge of someone else is great. So if you're reading a book, either joining a book club or sharing that book with a friend and having coffee or a discussion about it can be helpful. Taking classes, engaging in volunteer activities, gardening, Torah study. So these are my photos from our trip for my daughter's bat mitzvah last year in Israel. So we did a service activity. We picked some potatoes and we met some really nice people. I think there was actually a Park Avenue Synagogue delegation that was there like the week before or after us, but not the same week we were there. So we missed them. We met some lovely Jews from Long Island, and we played Jewish geography. So I in addition to just my shameless plug of my kids who I think are cute, I wanted to emphasize that being part of a community, which you guys are all doing right. You're here today. You're doing so. Congratulations, you have done some brain work today. So yeah, so having some of that activity be interactive and a little bit structured, like having a little bit of you don't have to be in the military, but you can have something that recurs in your week, something that's your every Wednesday afternoon chat with friends or whatever it is, or something a little bit more formally plugged in, like a class. I know that Park Avenue Synagogue has its activities. There's 92nd Street Y. There's LP Squared, that lifelong peer learning program. I think you mentioned Karen, like there are many different pieces to this. Okay, so I've talked to you about prevention. If someone is diagnosed with dementia, what can they expect in terms of treatment? What are the different pieces of the puzzle that we will want to treat? So first of all, I haven't really touched at this point on depression and other mood and anxiety disorders as it relates to dementia, but I'm going to talk about it here. Depression can certainly exacerbate dementia, and so therefore treating it is appropriate, but also depression can look like dementia. So if the person, if someone's in my office and what I am turning out to see is actually a really, kind of impressively severe depression that is significant enough to have meaningfully impaired cognition, on the one hand, that's really tough stuff, but on the other hand, it's also an opportunity, right? So depression is something that can respond, really well to medications and other treatments. So talk therapy, appropriate medications. There are some depression medicines that we tend to avoid in people who have cognitive challenges because some can make them worse, but there are some very cognitive friendly depression medicines that can be appropriate. Mindfulness activities, whether that's meditation or prayer, or can be helpful. Anything that's pleasurable, right? There's a sort of a fake it till you make it aspect of treating depression. So sometimes you have to go and spend time with friends and family, even though what you really feel like doing is crawling into bed, and even that doesn't feel that good. And shoring up relationships. So if it's what we call a pseudo dementia, meaning really it's a depression and not a severe cognitive impairment, then things potentially could really significantly remit and improve. But even if the depression is superimposed on a cognitive impairment that is genuinely there and is significant, there's still an opportunity for the person to think more clearly by treating the depression. So there's a part of your brain called the dorsolateral prefrontal cortex, and it's basically towards the front and the top and the back. It's got a very specific location, but so it is your brain's Google. It's your brain's search engine. And in cases of depression, your brain's search engine doesn't work so well. So you could have information that is actually quite well stored, but you can't retrieve it without kind of help and a nudge in the right direction in the setting of depression. So remove that blocker and you could be thinking a lot more clearly. We always want to reverse the reversible. So vitamin deficiencies, as I mentioned before, or any kind of medical issue that we find that's exacerbating cognitive impairment, we're going to move to treat. I realize this can result in people being on a lot of medicines, and polypharmacy itself is an issue, and there's a balance to be struck there, to be sure. I mentioned before something called normal pressure hydrocephalus as one of the causes of dementia. So that is when the fluid spaces of the brain get too big, independent of other factors. And it can create a picture that actually looks a little bit like Parkinson's disease, kind of shuffling gait, slowed down movements, downcast eyes. It can look like Parkinson's, it can look like depression. It can cause things like urinary incontinence. If we find somebody who has normal pressure hydrocephalus, that person can actually get what's shown in this image, which is called a ventriculoperitoneal shunt. So it's a neurosurgical approach. You literally need a hole in your head. Basically like a tiny shunt is made that takes the excess fluid off, and the person's walking can really improve remarkably, and the person's ability to get out and be about can improve as well. So we're always looking to reverse anything that we can reverse. There are some medicines that have been around for a long time that are used. These medicines are all that I've listed here were originally developed for use in people with Alzheimer's disease, but they've come to be used in certain other types of dementia as well. Especially they are used in cases of dementia that's secondary to cerebrovascular change, and sometimes in things like Parkinson's disease. So the top panel shows what you might expect. So if you took this first class of medicines called cholinesterase inhibitors, they work by essentially helping nerve cells talk to one another better. So nerve cells or neurons use electrical activity, and then the message reaches the end of the cell, and then a little like package of chemicals is sent to the next nerve cell, and then electrical activity again. That package of chemicals, if it's not able to stick around enough, it can mean memory trouble. And so these medicines work by trying to help the brain's own chemicals kind of send their messages more effectively. The most famous one is Aricept. I guarantee you all know one or more people who are on it, even if you don't know that you know people who are on it. So these medicines have been around for a long time, and in the top graph, what I've tried to show here is what we expect from them is to give a plateau. So they don't change the underlying disease, but they help the person to perform at their current functioning, or maybe even a little better their current functioning for longer. Eventually the person will start to decline, but you can see that between the green line and the red line, there's always a gap at any point in time. So long as the person can tolerate continuing the medicine, we tend to leave it on even if they're declining, because they'll be able to maintain that gap. And then the bottom panel is a medicine called Namenda, which similarly kind of tries to give people a plateau. It tends to be pretty well tolerated. It doesn't give quite the nice bump that the first class does, but it can give a plateau. It is a little bit annoying to get onto because you have to do like a titration pack, but once you've gotten through the first month or so when the doses are changing, it's relatively smooth. Excuse me. So these medicines have both been on the market for more than 20 years. They can be used together. They don't have a ton of interactions with other medicines, and they are used pretty commonly. It is fair to criticize them and say that they are of modest impact, but it's also fair to use them. You might have read about some recent medicines that have come out, and I know somebody had submitted a question that was about kind of what's changing in the treatment landscape. So I'm going to talk about these two medicines as a group. One of them is called Leqembi. I know it's got a Q, but no U. I didn't name it. And the other one is called Kisunla. So they are both antibodies against the amyloid protein. So if you recall earlier, I mentioned that amyloid and tau are two proteins that are present in the brains of people who have Alzheimer's disease, and those proteins are wreaking havoc on those brains. So these two medicines are antibodies against those proteins that help to clear out those proteins. So the top diagram shows the way that Leqembi works. So it works on what are called oligomers, which are like small clusters of proteins. Kisunla works on bigger clumps of proteins. So they attack the problem a little bit differently, but they have a similar idea behind them. They are complicated for a few reasons. One of them is, so they're only meant for people who have Alzheimer's disease, right? You can't give somebody you can't give somebody an antibody against a protein they don't have. So it can't be, I think it's Alzheimer's disease. It has to be, I know it's Alzheimer's disease. The person has to have additional appropriate tests like a PET scan. A second thing that's a little bit more complicated about them is that there's a window in which they can be effective. So people who've had severe disease for a long time actually can't receive any benefit from them. They're also a little bit harder to get. They're infusions. So it's not a pill that I can write a prescription for and send somebody to a pharmacy to pick up. It's an infusion. The person has to go to either a hospital department or an infusion center. There's standalone infusion centers that are scattered around the New York area. They are, depending on which one you and your doctor might decide to have you on, they could be an infusion every 2 weeks or an infusion every 4 weeks. They are more powerful than what we had before, because unlike the previous slide where I showed you that the the oral medicines can give you like a plateau in terms of symptoms, but they don't change the course of the disease. So these actually go and suck up the proteins that are causing the disease. So they can change the course of the disease, and they can slow down progression in a more significant and longer lasting way than the medicines that we had up to this point. So that's great. They're also complicated because when you go with the equivalent of a vacuum cleaner into somebody's brain, and you're taking, you're mopping up proteins that have been there for a while, you can cause some dysfunction, and sometimes blood vessels get leaky, so people can have, reactions like swelling or bleeding around blood vessels in the brain, and that's obviously something that has to be taken seriously. So these medicines come with a lot of monitoring, a lot of MRIs, et cetera. So they're a big undertaking. Many people choose not to proceed with them. They feel like they're too new, or they're just too the risks attached to them are not acceptable. And it's, what I say to patients is, it's your decision. It's reasonable to say, hey, this is a big problem for me. I want to do something, even if it comes with significant risks. It's also reasonable to say, wow, those risks sound like, unacceptable to me. I want to invest my remaining resources in a different direction. So these are kind of the talk of the town, so to speak. Another branch of thought that I don't have a specific slide for, but I just want to mention briefly in terms of kind of what's new and what's interesting is there's a class of medicines called GLP-1 analogs that are very popular. They started out as diabetes medicines, and they've been used for weight loss as well. You might have heard of some of them, like Ozempic or Mounjaro or Victoza. So there's some recent small studies that suggest that those medicines might help out in limiting how much amyloid and inflammation develops in brains of people with Alzheimer's disease. So I didn't give them their own slide because I feel like they are still in the maybe category, but they are definitely an interesting and evolving story. So that's my story, and I'm sticking to it. So I think I've given you, a few different areas of thinking about this issue, ranging from what it is to how we get it to what we do about it. Thank you all for coming to hear me talk. I'm going to, if it's okay, shut down my slides and unshare my screen, and just answer questions as they arise.
Thank you so much, Dr. Gunther. That was such a great overview and great sort of detailed explanation about lots of different components of the disease. We have tons of great questions already in the chat, so I'm just going to go through them, and some of them we may have sort of addressed, but we'll get to as many as we can. So the first question is, does Pilates serve the same position as Tai Chi, or the same function as Tai Chi?
So sorry, my doorbell just rang, and the person in the other room is not there. Bear with me for 1 sec. Give me literally 1 second.
Sure. These are the delights of being a full-time practitioner and giving lectures.
Sorry, my wonderful receptionist has a horrendous commute and is also pregnant and is trying to limit her days in the office. So I said, never ever leave me. I want you to stay. If that means working remotely today, please do it. So I apologize for the disruption. Okay, so the question was about Tai Chi versus Pilates and their benefits. Right, so there is some overlap in their benefits, and they're obviously different activities. I will say so Pilates is, I think of its great benefits as being One is that it can address a lot of the factors that lead to back pain. And so because of that, people can wind up on less pain medication. Pain medication, can gum up the works of our brains. But, it is also, PS, it is engaging, right? I mean, any activity, especially activity that you tend to do in a class or a lesson, is also going to serve as cognitive engagement. And it can also be helpful with balance. But I think the pain piece of it is really key. So Tai Chi, I think the benefits also include balance. There is like an interesting kind of beneficial mental slowdown that occurs as people do it. And I don't mean slowing in the sense of, having a medication on board, but more like in the sense of mindfulness, right? And that there's some interesting recent data that suggests that it has some direct cognitive benefits as well. So they're both great. Pilates is sometimes a little easier to do with just a video in your home or some moves that you already know and a mat. Tai Chi is you can do that way too, but I think is a beautiful way to take advantage of being outdoors. Now is a great time to start practicing it.
Thank you. What do you say to someone who is commenting that she has not seen her parents and wants to see them, but the parents are deceased? Somebody with
I think
dementia.
the question is the person is impaired and does not remember that the parents are deceased. So this is a great question, and it gets into, I think, a little bit of the art, not science, of medicine. So I think it depends on the person with whom you're dealing. I would say there are some circumstances where someone says something incorrect and you have to correct them, right? From a safety standpoint. So it's 20 degrees out and the person is insistent that it's summer and wants to go out in a t-shirt and shorts, right? In that case, even if it results in a conflict, you're going to fight that fight, right? That is a hill that you have to die on because there's a safety factor attached to it. In other circumstances, when a person is saying something that's incorrect because they're chronically confused, I think it depends a lot on your relationship and how well you feel you can pull off kind of being kind and compassionate without feeling false. Like if you're not going to be able to do it with a straight face, even somebody who's forgetful can read you and knows when you're being false. I think something that I talk a lot about to the family members and caregivers for my patients is just the golden rule, right? I mean, we want to treat other people the way that we would want to be treated if we were in their shoes. So that's how I'm thinking about responding to remarks like, oh, I want to see my dad, et cetera. Yeah.
Yeah, thank you. Somebody asked about where the video will be posted, and we will send out a recording and some other resources and Dr. Gunther's contact information for her practice in an email after the session. So anything that was sort of talked about, we'll make sure to put in an email to everybody. If you notice the abrupt onset of short-term memory loss, what is the differential diagnosis? I know you sort of addressed that in part.
So if something were to start very acutely, so if I get a call from, let's say, a colleague who's an internist, I have a patient in my office who everybody's really sure that this is very different now from a month ago, right? So the differential diagnosis or the list of things we suspect is overlapping with, but not exactly the same as the list that I would have given you that is more things that happen chronically. So first of all, it's always possible that it actually is something that's been brewing for longer, but something has tipped the person over, right? So sometimes the person who has the very beginnings of Alzheimer's disease, where the symptoms are actually quite mild at present, will get an infection and then will, and then will kind of very acutely look worse. But if it's truly, sorry, can you see me?
Yes.
Okay. But if it's truly something that is rapidly progressive, there are some other disorders. Some of them are what are called paraneoplastic disorders, which is like, if your body is trying to fight off cancer, sometimes it will very less aggressively make antibodies against that cancer, and those antibodies can actually cause like an autoimmune response in the brain. That looks like dementia. So there are certain things like that, or I mean, there are very rare things like rapidly progressing tumors or like prion infections. I know like a bunch of years ago, everybody was really wild about, you know, mad cow disease, right? I mean, those are actually incredibly rare. But in the setting of, if it truly is something that has moved super rapidly, the list does shift towards some of those more rare things. And when I was mentioning the kinds of tests that you might expect, that's where some of those extra tests, like a lumbar puncture to get cerebrospinal fluid, like that's where some of those might come in.
Great, thank you. Let's see. Just lost my place. In your opinion, do the risks of current therapy for Alzheimer's disease outweigh the risks?
It depends on the therapy and the person. So for the newer medications, I think what I mentioned is that, you know, there's a concern about changes to blood vessels, right? Bleeding and swelling around blood vessels in the brain in people who are treated with Leqembi and Kisunla. And those risks depend partly on your genetic profile. So that is where genetic testing might come in handy. You know, I would say I believe in them enough that I prescribe them, but I also am very cautious about them, and I don't have a million patients who are on them. It's, you know, it takes me a pretty lengthy conversation with the patient and the family members to make sure that we're all on the same page about just what it is that the person is doing. And I would say, you know, my patients are my teachers, so I hear from them a range of responses. I've had some people say, I'm in pretty good shape right now, and I actually want to do everything I possibly can to stay in this good of shape. So yes, I want them, even though I know the risks. I've had other people say, I'm a little older than is typical, and I feel like I've got other medical issues that are actually going to be bigger fish to fry for me. I don't want one more infusion. I don't want one more confounder, one more thing that I have to worry about. And then I've had people, you know, sort of a different mindset, saying, I actually don't want to be tethered to one place. I have mild cognitive impairment. I know it could get worse. I just retired. My grandkids live across the country. I want to be there every couple of weeks, and I want to travel. And I just don't want to be tied down. And for me, the benefits of maintaining my current, you know, kind of social and other commitments outweighs the benefits that I could receive from medication. So I think all of those are reasonable stances to take. I think it's a person by person response.
Yeah, thank you. What is your opinion on bread's effect on the brain, the grain brain?
I wish my colleague who's an allergist were here to talk about this a little bit more. But so there's a lot of talk about inflammation, and inflammation seems to mean everything and anything to everyone and anyone, right? I do not think that there is adequate evidence to say that you know, grains are fundamentally pro-inflammatory and should be completely eliminated from our diet. You know, and that said, I do think there is evidence that how we process sugar changes, and you know, and I mean, basically grains are a source of carbohydrates, and we want to be mindful for that, and we want to be mindful about clean eating overall. There are two studies that I think of when I think about this issue and similar issues. One is, about probably 10, 15 years ago, there was a study that was done in one of the Nordic countries. You can never pull this off in the United States, but they basically jailed people for a year, and they made them eat perfectly and exercise perfectly. They made them do everything right. And they put them on very low carbohydrate and also heart healthy diets. And these were people who had mild to moderate cognitive impairment, so MCI or maybe mild dementia. And at the end of the year, they looked at how much improvement that they could show, and they showed a little bit of improvement. What they didn't show was a full reversal. And the other study that I think of is there's a woman in the Netherlands who has looked at what she refers to as super healthy centenarians. So she looks at people who have reached 100, and they're not just surviving, they're thriving, right? They're not limping to the finish line, they're looking great at 100. And she compared them to both their age-matched peers, so other 100-year-olds who are less healthy, and she also compared them to 80-somethings. And what she found was that compared to the other 100-year-olds, they actually didn't behave much better. They weren't radically better on diet and exercise, right? Would they have potentially fallen ill younger if they hadn't behaved themselves? Yes, but what they did have was a combination of, I think, one is low risk genetic profiles, and two, they didn't have kind of crazy high rates of abuses, right? Like they didn't have, really horrendous lifestyles. So this is probably a longer-winded answer than the person who asked the question was hoping for. So, but what I would say is specifically with regard to grain and kind of the idea that like that FODMAPs or the things that come along with grains and the sugars themselves are kind of should be fully avoided. I don't think there's enough to make that recommendation. Do I think that a higher protein diet is probably on the healthy side? Yeah, there's some evidence to suggest that in kind of in like 60s and beyond that does matter.
Great. That's very interesting studies. Thank you. Another sort of question, and this was also asked in the registration. Have there been any studies showing whether ADHD, OCD, or people who are on the spectrum are more or less likely to get Alzheimer's? And similarly, do depression and general anxiety disorder increase dementia risk? I know you talked a little bit about the connection between depression and dementia.
I'm going to answer that a little bit backwards. Yes, there's a link between chronic depression and long-term dementia risk. And how much of that is mediated by depression and how much of that is mediated by medications or kind of other, kind of behaviors and activities is, I think, sort of open for debate and warrants more exploration. There's also the phenomenon that I described where, right, a current depression can look a lot like dementia, even if it might not be dementia. So I think both things are true. In terms of, I'm not aware of any link between OCD and dementia. ADHD is tough because we actually don't have a ton of longitude with ADHD, right? It's a diagnosis that in earlier generations got missed. There's definitely not a strong link with the existing data, although the specific symptoms of dementia, like the way that dementia looks, can be a little bit different in ADHDers because kind of the things that are normally challenging for them, like it's a different list of challenges, right? So it's informed by, but not kind of causally connected.
Mm-hmm. I'm sprinkling in another question from the registration. What should I do if I notice changes in my loved one, but when we go to a neurologist and talk to a neurologist, my person sort of passes the cognitive tests and looks good according to the neurologist?
So the family is noticing something, and it sounds like the patient is at least open to being evaluated, but is kind of cruising through, right? So I think the first thing I would do is, I mean, if that's a concern you have going into a neurology appointment, I think it's something you absolutely need to bring up during the appointment, right? Is that, we're seeing things at home, we're seeing change in function at home, that is definitely there. So, and that's one of the reasons why, when I kind of described the domains of cognitive function, I gave you some examples of the things that I'm listening for, that might be working or not working so well at home, right? I'm not just relying on a paper and pen test. So I would say, you could, right, so bring it up with the neurologist, ask if it's possible to come back in 6 months, for a follow-up. I would say there are, this is not the right answer for everybody, but it might be the right answer for some. So in the past couple of years, the ability to look for amyloid in the bloodstream has gone from non-existent to actually not bad. It's less reliable than something like a PET scan, and it's not a test that I use all the time. But when I have someone who is saying, I know you're not picking up on something right now, but I really feel like something is kind of coming down the pipe for me, I might say, you know what, we can use a blood test as kind of an interim marker of like, how high is your risk over the next year or two? How tightly do we want to keep an eye on each other?
Thank you. Somebody's asking about the role of neuropsych testing.
Sure. So neuropsych testing, just to clarify for the people who weren't asking the question, right? So in some circumstances, a person might go to see a neuropsychologist and have essentially the equivalent of IQ testing, right? So not just a certain amount of paper and pen testing that I could do in my office, but really more like someplace between a 4 and 8 hour battery of tests that is purely cognitive testing only. So there are circumstances in which we would use it. Actually, one of them might be in the example that we just discussed earlier, right, where the physician in the office isn't picking up on something. So especially, I would say, in a patient who's a little bit younger than is typical. So sometimes, let's say, I've got somebody in their 50s who's come to see me. That's not an age at which it's common to be developing Alzheimer's or another type of dementia, but never say never, right? It does unfortunately happen. If in my office, the person is really kind of hitting the ceiling of all of my tests, like they're just cruising through, but they're saying, I work in a very demanding job and I know that there's something different about how the way that I conduct my job, that might be a case where a neuropsychologist can tease out the beginning of something that I'm not finding. So I would say there's a role for it there. There's a role for it also in, there are some neuropsychological tests that can try to assess the role of personality factors in shaping how we learn and remember. And so for someone who has maybe a very complicated psychiatric history, where depression or anxiety or another psychiatric disorder shapes the way that they answer questions to begin with, maybe their neuropsychologist can really add some value to.
Thank you. A next question, and I wish that we would have time to get to all questions because we have so many great ones. But we have a couple more minutes. I think this may be the last one. But what is your opinion on nucleoside reverse transcriptase inhibitors, NRTIs, a common class of medications for HIV, and its ability to decrease the risk of developing Alzheimer's disease?
Yeah, it's an interesting and very, very unproven brewing story. I have not seen something that I personally view as compelling, but I'm in small stories, I'm always open to more data down the road.
Okay. All right, I'll ask another one. What do you think of luminosity? And you mentioned board games for people with mild cognitive impairment to improve memory.
So Lumosity, the company did they actually tried to do some rigorous scientific testing, and Lumosity did a really fabulous job of proving that people are capable of getting better at playing Lumosity. With great scientific rigor, they have shown that Lumosity can make you better at playing Lumosity. They've also been able to show that in healthy normals, so people without a neurodegenerative disease, they may get sharper in certain ways that exceed Lumosity, like certain forms of fluid intelligence that might improve. So what they have not been able to show is the following. They haven't been able to show that they can reverse a problem that is there. So once somebody has, actually has a diagnosis, no. And they also have not been able to show that they are superior to other more interactive forms of engagement. So if you like computer games, Lumosity actually can be fun. Like if you enjoy it, it can be fun. It is certainly not harmful, and it might make you a little bit sharper if you're basically healthy. But it certainly should not take the place of something that you could do that would have a human being on the other end of the interaction.
That's great advice. Thank you. So I think I just want to sort of close now. and say thank you so much. We're so grateful to you for
you.
being here and sharing your expertise on this really challenging condition that touches so many lives. We, especially this year, the synagogue is really invested. We've become very invested in having these conversations and raising awareness and providing education on both mental illness and also dementia. And I just want to sort of name, and this came up in a number of questions, how much a family member's illness, whether it is mental health related or dementia, can really impact not just the person with dementia, but also the family as a whole and all of the care partners in a person's life. And given that Park Avenue has been partnering with an organization called Caring Kind, and I'll make sure that that information is in the email, to offer both psychoeducational groups and groups that offer support, because a big part of supporting a person with dementia, especially as things progress, is to be able to help sort of manage some of these behaviors or unmet needs that somebody may exhibit that can be challenging. So the question about how to sort of redirect or respond to somebody who's asking for their parents when their parents have passed. So just want to sort of plug that we'll probably be offering our next groups in the late summer, early fall. So if anyone's interested in learning more, please feel free to reach out to me, and I'm happy to talk about it more. Our goal, again, is really to shift the culture and conversation. So hopefully this is just sort of like the first conversation of many to come. Like I said, we're going to be sending out an email over the next couple of days with this recording, contact information, resources. So if you have questions and want to be in touch with Dr. Gunther's practice, you can reach out. Schedule a meeting. If you didn't register and would like to get this email, please email me or Adult Engagement, and we can make sure to include you. So thank you again, Dr. Gunther. Thank you to Rabbi Zuckerman for lending his class time. Thank you to Patricia for coordinating this program, and to everyone for your thoughtful questions and discussion. And we hope to see you again next time. Bye-bye.
Thank you so much.
Excellent presentation. Thank you.
Thank
Bye-bye.
you.
Thank you. It was excellent.
Yeah, we would love to do it again. Sure. It's excellent.
Great. All right. Thank you so much, Dr. Gunther.
Thank you. Thanks
We'll
for
be in
watching.
touch. Okay. Bye-bye.